Definitely. Thank you so much for everyone for joining in. Horizon is just our effort to bridge the gap. We started as a foundation. I am not going to present something extensive as to respect everyone's time right now. But Zarurat Care is a foundation. We started as an initiative for biliary tract cancer, supported by Dr. Javle, Dr. Sevanti, everyone over here. But we felt that there is a need to bridge a gap between all the GI cancers in India with the rising incidences, and we truly work with patients. Our core, our heart lies with the patients, but we felt that we need to bring a platform for oncology where international experts can share their knowledge and latest research which is going on in India, so that we can appreciate more of translational oncology in India. And that's why we are here, and we are truly glad for everyone to be present and contributing their time and efforts here. So I think with this we can start with Dr. Ayer's talk. Truly honored to have you here.
Thank you all for that very kind introduction and the organizers and sponsors for putting this together. I'm excited to meet you all virtually and hopefully someday in person. I've met Priyanka, but hope to meet all of you. I'll start to share my screen if that's okay. Um, Let me know if you're seeing it.
Yes, we can see your screen.
Okay, good, good, good. As you've already heard, I am still at Roswell Park for one more week. Behind me are all the boxes, and very soon I will be at the NCCN. I thought I'll spend the next 30 minutes or so just giving you a little bit of an overview from where I sit today. This is the last lecture I'm giving as a medical oncologist on staff at Roswell Park. So a little emotional about that because I'm moving, but also because of the work that remains to be done. So much has to be done. It feels nice to look back and see what you did, but the work ahead is so big. So we'll talk about diagnosis, surveillance, some challenges that we face, and a little bit about first and second line treatment options. I have practiced pretty much for the last 21 years here in Roswell Park in the US. So some of it is coming from that perspective, but I know it's not very different in terms of the available drugs there. Just the sequence of how they got approved might be somewhat a little bit different. And some future directions, work that we did, some work that I'm excited about that I hope to look forward to seeing come to fruition in the years to come. So HCC, as this group knows very well, is 85-90% of all liver cancer, the remainder being cholangio and some other rare cancers that this foundation and your group and Millen's work especially has really taken it to a whole new level in our understanding and our treatment. Sixth most cancer worldwide, third leading cause of death. All of these numbers really just go to tell you how urgently we need options. And India and Asia, Africa are all the places where the need is the biggest because this is much commoner there than even in the West, but increasing in incidence with hepatitis B and C still being the commonest, but rapidly non-alcoholic liver steatohepatitis, NASH increasing as a cause. And diagnosing it, as you all know, is very difficult. 80% of these patients are diagnosed late. Even those who go for surveillance, sometimes the interpretation of the scan or the frequencies, the going back and forth is not very easy to the doctors. A lot of times it's ignorance of who to screen. Many times it's from the patient's end too. The follow-up is difficult. We all know, those of us who are the age group, to go for mammograms and colonoscopies, even things that are once a year or once in 5 years, we're not always very compliant. So something that requires every 6 monthly follow-up is not very easy. But all guidelines still believe that every single one of them, that screening is important, early detection is really the goal. And eligibility criteria across the board are anyone with hepatitis, anyone with cirrhosis, and HBV, because it can cause cancer even in the absence of cirrhosis. Those people, even if they're treated, need to continue to be surveilled. And in terms of staging, we've come a long way here as well. We have many different staging systems because this is the one disease where it's not just where the disease is, but it's also the liver function, the overall comorbidity and health and age, and so many other factors that play into the decision making as well as the outcome. And BCLC has historically been the sort of guiding, they've really paved the way in how we think and approach these patients more so than TNM staging. And here they're incorporating, several other features, not just where the tumor is, whether the size is, in transplant criteria, resectability, ascites, and, other things that you all have to have in hand when making a decision in the clinic. And the clinical algorithm, even though we'll be talking most of this, hour and a half about advanced disease, we must not forget that when we do sometimes find someone who was diagnosed early, or, just keep that in the back of our minds. Is this something that can be ablated? Is this something that can be transplanted? And in that appropriate patient, stage 0, A, and even up to B, sometimes, just keep that in mind. What local therapy do we have for this person that could give us a prolonged survival without, or potential for cure without all the toxicities? So for the bulk of this time here, we will talk about the BCLCCs, and unfortunately, the Ds we can't do a lot because their livers just don't have the reserve. And in the US and in India, the history of systemic therapies has been really, for the longest time. When I started in Millen's Clinic, we had nothing. We really just did TACE and gave doxorubicin back in 2001 when I was a fellow. And then when sorafenib came and beat with the SHARP study and the Asia Pacific study, placebo, really, that was the standard. It was like nothing. Overall survival moved to 10.7 in the Western world, and in Asia and the Asia Pacific region, somewhere around 7-8 months for those with Child-Pugh class A. And the big thing that we learned from that was that we knew chemotherapy doesn't work, but we learned that VEGF therapies can have value, can have benefit in this group of patients. But we also learned that you have to carefully select them. You have to pick Child-Pugh class A patients, because there the liver failure is not competing as a cause of mortality, and you're really actually able to measure the effect size without that sort of confounder of the failing liver. But it took a really long time before any other drug really could beat or match that result, until the approval of lenvatinib from the REFLECT study. We'll talk about that in a minute. And then it wasn't until 2020 when we finally got the results back from the IMBRAVE 150 with the approval of atezo-bev. And shortly thereafter, also in 2022, with a little more mature follow-up data from the Himalaya study looking at durvalumab and tremelimumab. And along the way, while these studies were going on, with sorafenib as the first line, several other drugs were studied in the second line studying, using sorafenib as the primary or sort of initial therapy. And all these other options have then since been approved and are still available and are being used. We'll talk about them as well. So in terms of the approved systemic therapies right now available to all of us, in the world, really just fall under two broad categories. They're multi-kinase inhibitors. And we're learning more and more when we started to sort of present them to our patients in clinic, or even think of them, we thought of them as VEGF, RAS, RAF, MEK, few other pathways that they target. But over time, and we'll share this a little bit as we go along, we're learning that they also have some immunomodulatory effects. And the more sort of clear immune targeted agents are all the immune checkpoint inhibitors with PD-1, PD-L1, as well as CTLA-4 inhibition. And that combination is quite potent and has benefit in this disease. So in the US, how do we treat? And in India as well, I know from having looked at some of the NCCN data in my new role, that the guidelines from NCCN are used all over the world, and especially India is the highest download for the guidelines. So it is being widely used and referenced. But there are many other guidelines, AASLD and ASCO and others, that put out guidelines, and they use different methods of how they collate that information, and they come from a different perspective, each of them. I think one of the big sort of advantages or sort of positives with the NCCN guidelines has been that they're constantly updated. And so you get that information in a timely manner. And, it is up to interpretation, of course, in your hands to use. And we'll talk about that a little bit as well. But in all of these guidelines, they all come with the caveat of this is the evidence, this is what we know today. In situations where the patient did not get sorafenib frontline, what to do, we don't know. And all of those things create like nuances and subtleties that we have to sort of develop over time as we practice. So in the most recent version of the NCCN guidelines, in the first line setting, we have atezo and bev with category 1, meaning that there is really strong evidence that this works, and there is FDA approval for it, and the risk-benefit ratio really favors that this should be used. Clinicians in the NCCN centers are actually using this in their clinics. Tremi and Durva has also a Category 1 approval, and all the other regimens are listed as other recommended regimens in part because of the survival difference that was reached with these combinations. Also to note is that this, I know this is a rare, thing that happens. We often don't even have tissue with our patients with HCC. Looking at, RET genes or fusions or NTRK or some of these other targeted mutations is something that we should keep at the back of our minds. And when we do have tissue, try to look for other targeted options or trials. So I thought I should also share this if some of you have not yet had a chance to try it. The NCCN realizes that the guidelines are getting really big and massive, and they're just expanding, and it's getting harder and harder to even navigate them. So an online version that is a little more, sort of user friendly is being created, and it's going disease by disease, and the hepatobiliary one is ready. And so there you can really just type atezo-bev and it'll tell you all the places where atezo-bev can be used and different like HCC screening. I just sort of was playing with it. And so if you have a moment, and it is challenging when you're in clinic to when you're seeing patients to learn or know what to do, these guidelines can help you navigate through. The navigator can help you get to that right page or right place where you need to. And another thing that might be helpful if you're setting up, if you're a physician that's starting a new practice, there is also the NCCN compendia for drugs and biologics. And there you can get templates and order sets and things that are downloadable that you can use as you start your practice. So these are our three available sort of frontline approved options that are being considered very actively when we see patients in clinic. The first actually is the REFLECT study. We got lenvatinib from a non-inferiority design when compared to sorafenib. This study was done all over the world. And the important thing to note here was that they excluded patients with varices and mean portal vein thrombus. And this was an oral option, so very convenient for patients who may not have access to come in for IVs or time or so on and so forth. And the median survival that we reached with these oral pill options was in 13 months, 12-month range, which is where we were for a very, very long time. Response rates were surprisingly, good with lenvatinib with 24% compared to 9% with sorafenib, and discontinuation rates were quite low, just 7%, even though a lot of patients did have grade 3 and 4 AEs, 75% of them. And then IMBRAVE 150 was completed. And finally, we moved survival to 19.2 months compared to 13.4 months with sorafenib used as the backbone with a very good hazard ratio of 0.66. But of note, this study, when they'd done the initial phase 1 and phase 2 studies, had seen some bleeding episodes, and therefore they made it mandatory that all these patients will have had screening for varices and excluded these patients because of the risk of GI bleeding secondary to bevacizumab. And with that, screening criteria, they did have bleeding episodes about 6%, and discontinuation rate of this regimen because of toxicities was about 22% from immune AEs or any other toxicities. Grade 3 and 4 AEs were seen in 63% of patients. But what was very impressive was that the quality of life for these patients, their deterioration was slowed, meaning it was tolerated and people felt well, which was not the case in the SHARP study. And also the overall response rate was really impressive at 30%, with about 8% of them getting complete responses. And patients were treated for 2 years or toxicities and then stopped. And I've personally seen some patients, as I'm sure you have as well, who may not have had a complete response. They've had a very deep, good partial response, and they have some residual disease. So we're not calling them a CR, but they're off therapy and they're doing really well. And that has been very wonderful to see as a treating physician. Losing your patients to HCC was the norm, and seeing them doing well without any therapy has been wonderful. But with the Himalaya study, we saw a lot more of that. We saw 20% of patients reaching that 3-year and 5-year survival, the tail of the curve, even though the response rates, the overall response rates were lower, only 20%. Those that got responses had very durable responses. Overall survival reached was 16.4 months with a combination of durva and tremi, priming dose, just a single dose compared to sorafenib. And they also studied durvalumab alone in this group of patients for those where the concern was that they may not tolerate the tremi and the risk of immune adverse events was high. And their survival was quite similar to the sorafenib arm. So that's also a reasonable option and does have an approval to be used in that setting should there be a need. And one other little update here was the question of would it help to give more tremi? And actually, they did allow that as like a little footnote in the study and said if the investigator thinks that it would be of benefit, there is some progression, there is not rhesus progression, but some progression, and there's concern. It was kind of vague, but you can give a second dose of tremi, and it was given in 30-40 patients. And Dr. Katie Kelly did present that at GI ASCO just last week, but it wasn't really compared to anything, so it's really hard to say how much value that added. And so, with that information, the other things to keep in mind were about 13% of these patients discontinued because of toxicity, bleeding risk, even though they did not screen these patients for varices, was about 3.9%, sort of an inherent risk in this population that they might bleed. And 50% of them had grade 3 or 4 AEs. In this study, in the Himalaya study, they excluded main portal vein thrombus patients, concerned that they might not do very well. And this prolonged tail of the curve where people did well, not just for 3 years, but eventually also for 5 years, having 20% of them doing really well with a once a month infusion, has been lovely to see and has been great for patients as well. So, how to choose first line HCC therapies? In the Child-Pugh class A fit ECOG 01 patients, no varices, either option, atezobev or durva-tremi, and also ipi-nivo, we'll talk about that in a few minutes, might be an option. If there are varices, of course, concern for bleeding, durva-tremi might be the preferred option. And in patients with significant cardiovascular problems, claudication, stenosis, recent MI, so on and so forth, avoiding the bevacizumab might be how we approach it. In Child-Pugh class B patients, we really don't have level 1 data. Right now, those studies are going on. There is a study that's being run out of UT San Antonio looking at durva-tremi in the Child-Pugh class B. Roswell is participating. It's about to open. 10, 12 patients have been treated so far. And they also tried to do a study, or the Kiros study, with atezobev or atezo alone in Child-Pugh class B. It's been really hard to find those patients really to enroll them on the study, but those studies are ongoing. And for the moment, we only have safety data from large databases. So in all of these settings in Child-Pugh class B, considering some anti-PD-1 or PD-L1 monotherapy or reduced dose TKI, if possible, where there is evidence that there is safety, could be used. And few other special considerations, sort of getting a little more granular with the data that I just presented in the first slide that you all are very familiar. Macrovascular invasion patients, we do see these tumors are just stepping out of the liver, getting into the vein. And in those patients, we always wonder what will be the best. What is the evidence we have right now to know what will work? Because those were excluded in the durva-tremi as well as in the reflect study with lenvatinib and sorafenib. 40% of them were enrolled in the patient in the trial with IMbrave. In the IMbrave study, macrovascular invasion was present in 40% and 25%, in the Himalaya study. Extrahepatic disease was present, more or less similar, but a little bit more in the IMbrave study, telling us that the patients who were receiving that atezobev, that cohort of patients were slightly a little bit more advanced, or one would say a little bit sicker. VP4 patients were included in the atezobev IMbrave study, but not in the Himalaya study. And the complete response rates were much higher with atezobev, 8% compared to 3% with durva-tremi. So these factors might be at the back of our minds when we're making a selection. And these are just some exploratory analysis for VP4 patients. In the IMbrave study, we saw overall response rates of 23% versus 13% for sorafenib, and PFS and OS numbers are listed here. Just as we talk to patients and give them that information, we want to be able to tell them what is really expected for that cohort, because it's not quite the same as the entire median of the group. There are occasionally patients in our clinics here, and I know for bigger centers that have transplant available, patients who recur post-transplant, and for them, or if they have autoimmune disease, immune checkpoint inhibitors may not be safe, especially the PD-1 agents. And so TKIs might be more appropriate in that setting. And of course, there are some patients who just cannot do infusional therapies for different reasons, travel, cost, or whatever. And those, or some people who have really indolent, sort of slower biology option disease that would like to try something a little less toxic, and therapies like oral agents might be appropriate. So one other question that I get asked, and I know you also probably consider when you're seeing your patients, is should we change the therapy or select the therapy based on the etiology of the cancer? Are virally mediated cancers a little different than the NASH-related cancers? And at the moment in the guidelines, because prospectively this has not been evaluated, none of the studies were really powered to answer these questions. In meta-analyses, we are seeing that the benefit in terms of the hazard ratio is a little higher for the virally mediated cancers compared to the NASH-related HCC. The benefit is still seen across the board in all these patients. And I think some of the reasons for the difference, meaning the sort of greater benefit with immunotherapy in the HBV and HCV related HCC might be a little bit that might be in this sort of picture in this figure where HBV related HCC really has more of an immunosuppressive environment. It has lower expression of pro-inflammatory markers like interferon gamma, like tumor necrosis factor alpha, and tumor infiltrating lymphocytes from HBV related HCC also express more PD-1, making it sort of, in theory, likely that the ICI therapies will work better in this group because the target is there. Similarly, with HCV-related HCC, significant presence of exhausted CD8 positive T cells that express very high levels of PD-1 are present. And in NASH-related HCC, it's a little more complicated to explain this. In preclinical models, actually, when they've tried to, the way they create the NASH in these preclinical models is the diet that they feed the mice. And in those animal models, the immune checkpoint inhibitors may be exacerbating the NASH. And via some CD8 T cell mechanisms, both exhausted PD-1 high and effector cells, as well as CXCR upregulation. And some of these factors might be playing into how the immune checkpoint inhibitors work. And therefore, it's not a very clear answer as to why some of them do well and some of them do not. So in terms of selection, the approval of all these agents is across biomarkers and across etiology at the moment. And some of the reason for that is people have tried to look at Wnt and beta-catenin signaling, for example, which is present in 40% of HCC tumors, and try to see whether this activation had an effect, and was there a difference if you measured these markers and said, will there? The thought is that these markers might be implicated in resistance to ICIs, and if they were present, should you not use ICIs? And they did not find any correlation. And the same as we talked about with hepatitis B and C, in meta-analyses, you see benefit that is greater, but it's not that there is no benefit, or there is little less benefit, but that's not that there is no benefit when it's not a viral etiology indication. Similarly, with PD-1 or PD-L1 testing, there is no correlation. And so for that reason, this approval is across all biomarker testing options. So we don't have to really test for it. So moving forward into the second line, regorafenib was the first one that got approval after a dose of sorafenib that was tolerable, because regorafenib is really a sort of a stereoisomer brother of sorafenib. And the concern was, if they can't tolerate sorafenib, how are they going to tolerate regorafenib? And they did this as a placebo control study. At the time, there were no second line therapy, so it made a lot of sense. Overall survival in these Child-Pugh class A patients with Rigo was 10.6 months in the Rigo arm versus 7.6 for placebo. It remains a very good standard of care for second line therapy after any of the front lines that we just talked about, and has been approved in the US since 2017. Hypertension and hand foot, fatigue and diarrhea are the big sort of AEs. Cabozantinib was also studied around the same time and got an approval shortly after. Here it was studied both in the second and third line, and we saw that after sorafenib, if you gave it in the second line, slightly more benefit than if you gave it in third line, but similarly, 10-month survival for cabo in that second line setting versus 8 months for placebo, with PFS improvement, as you can see on the screen as well. Main toxicities here are diarrhea and hypertension, but pretty manageable. This population does well with cabo, as you all know. Pembro was also studied as a second-line therapy in the Keynote 240 study. And in this study, 13 months was a much higher overall survival. These are patients that had not seen a checkpoint inhibitor in frontline, just sort of validating and underscoring how important targeting the immune system it really is in the course of the disease whenever they can get it. But in this study, OS and PFS did not reach statistical significance at the required preset levels, despite these high response rates. And because of that, it is still approved, but stands as a category 2B in NCCN. Then comes the Ipi-Nivo, and it is approved now also as frontline, But it came in the US initially as a second line approval after the Checkmate 040 randomized clinical trial, where the questions they were asking were what is the right dose of a combination of checkpoint inhibitors that will work for this disease, because we didn't know. And there was some of this data that was coming from melanoma and other diseases that how you mix these combinations and how you stimulate the immune system matters. And so in arm A, which is Nivo 1 IP3, which is the regimen that was then studied in the front line as well, was where they saw the biggest complete response rates. Four patients had a complete response. Three patients in arm B, which was the Nivo 3 AP1, and in arm C was lower complete response rates. And based on this data, despite some of the toxicities, it received an accelerated approval in the US as a second line option. Following which, there was a study done, the Checkmate 90W, and I know we're going to talk about it a little bit more later on today with Tushar going over some cases and options. And in this study, what we saw was that the overall response rate truly with IP3 is much higher at 36% compared to 13% with len or sorafenib. And complete responses were seen in 8% of patients receiving this combination, which is it's hard to argue with that response rate, but it came at the price of toxicities. And the patients who did well had durable responses that lasted a really long time. But the toxicity rate is something that we all have to keep in mind. So at the moment, it is available, it is approved, and that discussion and the follow-up in terms of the durability of the response was just presented actually at GI ASCO that I'm sharing here. And that discussion has to be one that you have with the patient and sort of build your own familiarity with using it. And lastly, as an approved drug here in the US, this is the only biomarker-related sort of approval of ramucirumab, which was compared to sorafenib in patients with high alpha-fetoprotein over 400. And in those patients, the overall survival was 8.5 months compared to 7.3. So smaller magnitude of benefit, lower hazard ratio, but certainly an option for high AFP patients. So how to choose a second-line treatment? This is very difficult. This is a difficult discussion. So first line was immunotherapy. It's a little bit of an easier conversation. Cabozantinib, regorafenib is commonly used. What is the liver function? And so people have been using the ALB score, looking at the Child-Pugh score, and just overall what their actual liver numbers are to sort of see, are they well enough to tolerate what we have to give? And sometimes they are not. And in that case, best supportive care might be the best option. How quickly did they progress? Some of the rapid progressors on atezo-bev could be developing anti-atezo antibodies, and there is work being done to sort of understand that and see, should we then use a different ICI therapy? And other options, one of the studies that I'm involved in here at Roswell Park is to say, are these cold tumors and should we be kind of activating these tumors using some sort of oncolytic immunotherapy? So Replimune, RP2, RP3 are being studied in that setting as well in the second line setting. And another research area or gap that currently exists is what else do we have? Why are we stuck with just ICI and VEGF therapies? Since GPC3, glycoprotein C3, is often expressed, especially in the high AFP patients, is that a target and can that be targeted with all different available options? Histotripsy is another new ablative option that is available, and we've seen a few cases where we use that to treat the portal vein thrombus and sort of destroy it and see if we can alter a little bit of these patients' outcome from doing that. Or does having that portal vein thrombus really determine your longevity, regardless of whether that thrombus can be sort of eradicated? Local therapies can also be an option for some of these patients, like Y90. So moving for the next 3-4 minutes, I'll try to talk about the future, and sort of the future is big and bright and lots of things going on that I'd like to share a little bit of that I see. Many frontline options are being studied, not just novel combinations, but also novel targets. So some of these are radiotherapeutic agents, and some of these are also optimizing existing options that we have in earlier stages. Besides the studies I talked about in Child-Pugh class B, some biomarker work is ongoing. Emerald 1 was a positive study with TACE, and more studies, more follow-up is required from completed studies like IMbrave 050 for adjuvant atezo-bev. Some of the studies that I have had a chance to be involved in here at Roswell, and I'm excited about and looking forward to in 2026 and beyond. One of them is the earlier use of IO VEGF with Durva-Bev, combining it with Y90. I was fortunate to co-lead with Riyad Salem, a wonderful interventional radiologist at Northwestern, the Emerald Y90 study. It has completed enrollment. And what I'm excited about this study for, not just because it's a novel combination in the earlier setting, in a BCLCB setting, but also because we did something different. A lot of these liver-directed therapies, as you know, trials had failed previously, and some of it was the quality control of the liver-directed modality. And here, rather than do central review after the fact, we did central review during the course of the study. So there was central review of the delivery while the patient's mapping and planning was being done, allowing a little bit more of a controlled delivery and selection of patients. So I hope that if that is positive and that is ending up to be a new sort of option for that group of patients, that that trial design also serves as a benchmark or something to follow and emulate in future trial design. I briefly mentioned the GPC3 CAR T has made a big wave and made a big impact in the heme space. And the question of where it's going to land in the solid tumor space is always a question. HCC is not a disease that people really want to venture into when you have something toxic or sort of a little scary to give. But GPC3 is available or sort of expressed rather in 70% of HCC patients. The level of expression varies. And so here in this particular study developed by Eureka Therapeutics, the ARIA-3 study will be submitted this year. The phase 1 is done. The phase 2 expansion is about to begin, is looking at a GPC3 targeted therapy. Now in the phase 2 will be combined with some priming regorafenib, and a late-breaking abstract will be submitted with some of these early results to ASCO 2026. So if there is going to be an approval for a CAR T in solid tumor, I hope and I feel that if it's going to happen, it will be for this target and this disease. And lastly, Sayan Chakraborty is a brilliant scientist. He moved here from Singapore and studies agrin in the extracellular matrix. And what is agrin? In this figure, I don't know how well it's projecting on your screens here, but even whatever you can see, if you have low, if there is no agrin expression, your extracellular matrix has a different, less complex structure. And in the presence of agrin, macrophage maturation is affected. Many other immune cells are functioning in a different way, and that might be contributing to ICI resistance, is what Sayan's work has shown from all of his papers. And this is a figure from our Cell Reports review article. And we're trying to find ways to use agrin both as a biomarker and as a target. And we're still working on it. This is sort of far away. So Emerald is ready to read out. GPC3 CAR T phase 1 is ready to read out this year, both of these for this year. But agrin is sort of a more distant, a target or sort of dream or hope. But coming to closing here, what is going to be the biggest impact is still early detection and prevention. Don't get HCC or find it early is where the biggest impact lies. Majority of our patients, unfortunately, only 8 or 7% of them are cured. And finding this cancer early should still be our goal, even though majority of the audience here is, sort of seeing the late stage patients or meeting patients after they're already diagnosed. Focus on early detection, knowing those eligibility criteria, and developing personalized screening tools and risk assessment tools so we know who needs the screening, because there are patients whose tumors are found even in the intervals between the screening, even though they were going for screening. And some of it has to do also with how difficult this is to detect with ultrasound. And so those things are continuing as point one or one takeaway. And then these two other things that I wanted to also bring up. I was fortunate when I came to the US first to work in Philadelphia and Fox Chase Cancer Center, where I had the chance to meet Dr. Barry Blumberg, who won the Nobel Prize in 1976 for his discovery of the hepatitis B virus, as well as the antigen, which then led to us finding a way to vaccinate and prevent both hepatitis and HCC. And still the use and uptake of hepatitis B vaccination could be improved worldwide, and is still an opportunity for us to focus and screen better and treat better. And this is another exciting sort of place that I want to just put as a placeholder at the back of everyone's minds. Some work was done looking at green jackfruit flower and green jackfruit in general as a way to reduce and reverse fatty steatohepatitis. And as we know, this is not just a problem for developing eventually HCC, but also diabetes, which is a big problem in India and in many parts of the world. And some of these studies that were shown were really just for 3 months using a spoon of jackfruit flour 3 times a day in diet or in fortifying any other flour that's being used, showing some reversal in preclinical studies. And these are things that are developing and coming and things that we should keep at the back of our mind, because ultimately, if we can prevent this disease, we will have the biggest impact. And a couple of other things that we sometimes see in our clinics, or at least I see in my clinic, is a patient who comes after they've had surgery or an ablation. And the question is, should this person get something adjuvantly? And the IMBRAVE 050 study did show that there is a reduced risk of recurrence in that 2-year time period, but it came at a risk, with death. It was done during COVID. There were many other issues with that study. But the question is, did it really prevent HCC? And we don't have that readout just yet to know. But one thing we do know that will prevent secondary prevention of HCC is to give antivirals. So anti-HBV agents prevent HCC. And the reason we know that is because some of these studies were originally done in woodchucks. And I've been blessed to work with my mentor, the late Dr. Bud Tennant, who's a veterinarian from Cornell University, who discovered this model. Woodchucks get hepatitis just like humans do, woodchuck hepatitis virus, WHV. And at birth, when we inoculate them with serum from chronic carriers, they grow up and eventually become chronic carriers, 60% of them by 9 months. And by 2 years, they all develop HCC just like humans do. And these are sort of the multifocal tumors and so on and so forth. And what you can see here on the screen is giving antivirals. All of the current 5 antivirals that have been approved for hepatitis B were studied here in this model. And if you gave the animals the antiviral, you did not see the development of HCC, or you delayed it in these patients, in these woodchucks, the woodchuck patients, and the animals that got placebo, all of them developed, HCC. And the same has been studied in humans, and we've seen that in this many studies, but this particular study showing us that by giving antivirals after ablation or surgery, that you delay, and the hazard ratios were very impressive with 0.48 and 0.26 for decreased HCC recurrence and HCC-related deaths. So that's definitely something we should be screening for and treating. One of the other things that comes up or was studied for a period of time was, sorafenib. When I was practicing and giving patients sorafenib year after year and really no other options available to treat them, knowing that so many other more potent drugs like sorafenib that had similar mechanisms to sorafenib were not getting approved or not showing benefit. I wondered, does it have some immune effect? And working with one of my colleagues here in patient samples, what we saw was that sorafenib actually is immunomodulatory. And if it reduces the number of PD-1 positive cells, and that is also accompanied with effector function improvement. And we measured that as granzyme B production or interferon gamma production. So if you didn't just take away the bad cells, but that removal also resulted in effector cells sort of restoring or coming back to healthy normal levels, then patients did have the best survival. And that's what we saw in patients. And I wondered, and we saw that this did not have a dose-dependent effect. Whatever dose they got, it happened. So I wondered, in these woodchucks, since we can prevent HCC with the virus, can we prevent HCC with low doses of sorafenib? Is that why the STORM study failed, that the dose that we gave was too high? And when we did that study, we saw that, yes, you can actually delay in lower doses of sorafenib, you can delay HCC in woodchucks. But unfortunately, the benefit is not anywhere near the level of what you get with the antiviral therapies. So just little things that we're learning about the drugs we already have and the mechanisms we think they have, and just ideas to keep in mind as we design future studies using some of these biomarker studies and smaller trials that have been done that allow us to think through as we design our next generation of trials. So in conclusion, HCC really, as you all know, is a big global health problem, and early detection is really where the biggest impact will be. Anti-HBVs are one way to potentially prevent HCC recurrence, secondary prevention. And IO and VEGF, anti-VEGF combinations, personalizing approaches are really how we should guide selection. I'm really looking forward to the discussion. with Tushar about how, really all of us who are practicing are currently using the available data. Second line and beyond, and all these research trials that we are doing here and you are doing there. I know Darshit's going to share some of that as well. Will tell us where to go from here. We've come far, we've got a long way to go. And having access to all options, the supportive care, all the things that Priyanka, the Jarurat Care Foundation, and others that support the patients in terms of managing their liver function are all key for patients to not just survive, but really thrive with this diagnosis. And in closing, just Milind and all of you have been very kind in talking about my journey. And I just wanted you to know that the reason why I made this leap and sort of switch. The first drug to be approved for HCC was sorafenib back in 2007, and 10 more approvals came after that. But 40% of patients never get treated, and 80% are diagnosed late. And in the NCCN, the real mission is really to define and advance quality care, but to really push for equity and access to care. And so I think that impact that the NCCN can have globally is where I feel like I should spend the rest of my career. So no more trials for me, but working with the people on this call and others that are in other parts of the world that struggle the same struggles and wonder how we can get the care to those 40% who are currently not getting treated is where I would like to spend the next portion of my career. So with that, with many, many thanks to all the patients, the families who participated in the studies that I shared, the research teams who are the quiet unsung heroes behind the scenes, the funding agencies, the sponsors of this event, as well as all these trials, my mentors. I'm so happy to be doing this with you here, Milind, and collaborators for all their support, and for you for inviting me. Thank you.
Thank you, Renuka. That was a real tour de force, and so wonderful to learn about the journey for HCC, which has also been your journey. I'm going to move on to the next session. I'm really looking forward to learning about the burden of HCC in India. So I'm very happy to introduce Dr. Darshit Shah. So Darshit is a consultant in medical oncology at HN Reliance Foundation Hospital. He has been trained in Ahmedabad and he did his DNB in New Delhi at Gangaram Hospital. He has also had a DM in medical oncology at Tata Memorial, where he served as assistant professor in medical oncology. So he has been mentored by none other than Sevanti, and I'm looking forward to hearing about him, his work, and the burden of HCC in India.
Good evening, sir. Thank you very much for a kind introduction. And definitely, Seventy ma'am is my mentor. And a wonderful talk, Renuka ma'am. It's I think you have covered everything. From the entire landscape of HCC has been covered so well in a short span of time. So thank you so much. I would like to share my slides. I will be speaking about the India's role in global HCC. We all know the numbers: nearly 70,000 annual new cases and 65,000 annual mortality. Addressing the treatment gap in India, the main thing is less than 5% India's trial enrollment. The global average enrollment is around 15 to 20%. And the disparity highlights the clinical need for increased clinical trial participation in India for better patient care. We need more access to novel therapies, which will actually improve patient outcomes, and we also need a local evidence, for generation. Predominantly it's HCC is all immunotherapy and VEGF, but we do there are some trials I'll be discussing regarding FGFR inhibitor, MET inhibitor trials, targeted therapy. We all know that HCC is predominantly a tumor driven by WNT beta catenin pathway, and I'll be speaking about that in the subsequent slides. The barriers to trial enrollment in India are predominantly geographic access. still people are educated, but not very convinced, and still there is a lack of awareness. Participating in clinical trial, whenever we offer them, there are a significant number of patients which they kind of refuse to participate. There are economic constraints, including travel, accommodation. There is community outreach, financial support. There are so many barriers from the trial enrollment perspectives. So speaking on to the a few trials which I actually thought should be discussing is regarding the Morpheus trial. Predominantly, it's the HCC trial in which there were two cohort, etizole and bev, and the other molecule which was added was tiragolumab. It was a phase 1b trial where it was shown that the addition of tiragolumab showed significant PFS advantage as compared to the atezolizumab. However, to a surprise that in the IM Brave 152, that is skyscraper 14 study, we it was a phase 3 study. The inclusion criteria were similar. However, there was no primary PFS advantage, and both the curves were quite overlapping. So predominantly, what we have learned is, not every phase 1B or 2 study translates into a significant PFS OS advantage in phase 3. Maybe the reasons predominantly can be control arm was a small number, the patient population was not more diverse. Coming to the CAR T in HCC, we just need to see that there are so many pathways, but the main thing is WNT beta catenin pathway, and there's FZ region. We also have the GPC3, which actually it's downstream pathway. It functions through phasal FZ and beta catenin. It also has different canonical activations. So there is a GPC3 targeted CAR T which is under development. There are trials currently ongoing. However, in solid tumors, we have seen that there are so many limitations when we see data with very strong CAR-Ts in hematology, but solid tumors we still are not having very convincing data. So the overcoming resistance is to address antigen loss. Are employing they are employing dual targeting like GPC3 EGFR or GPC3 B7 H3 CAR T, which we'll be discussing. So the other thing in HCC is FGF19 overexpression, which is predominantly seen in nearly 30% of HCC, and it is actually associated with poor prognosis. It has also been shown that the patients who have FGF19 overexpression, the atezolizumab, the outcomes of atezolizumab are inferior as compared to the other subset of patients. So in this study, a drug called irpagratinib, this is basically a oral highly selective FGFR4 inhibitor. It has actually shown a promising anti-tumor activity in HCC. So it's a tongue twister. Irpagratinib with atezolizumab in the first line treatment gave with bevacizumab it was uh, used. It was a phase 2 study. And also the irpagratinib was also used in the SCC, which was actually pre-treated with immunotherapy in FGF19 overexpression. It was shown that it was superior when it was used in patients who had FGF19 overactivity. So this is one of the new drug. We need to have more data. It's still in the very early phase of trial. We have seen that sometimes early initial phase trials do not translate into actually survival benefit in the later phases. So current there is one more uh, drug called futibatinib. It is also a molecule which is basically targeting FGF9 overexpression. So it is being combined with pembrolizumab. Talking about the Emerald One study, it is actually a very positive trial where the three arms, predominantly the patients who are not amenable for curative resection, childhood A to B7, ECOG PS 0 to 1, and which are not BP3 and BP4. Basically, they have used durvalumab, bevacizumab, and TACE, and it has shown that the Emerald One study it is positive with a hazard ratio of 0.77. At 12 months and at 18 months, also the disease case is superior as compared to the standard placebo plus TACE. So this is the curve. We can see that there is a clear-cut separation of both the curves as early as 6 to 7 months. Coming to the other trial, it is also basically LEAP 012 study, predominantly combining pembrolizumab plus lenvatinib versus placebo plus TACE. Like Durva and bevacizumab, it actually combined pembro and lenva with the TACE. The inclusion criteria, eligibility criteria were predominantly similar. There was, no portal vein thrombosis or extrahepatic disease. However, there was stratified into study site, alpha protein levels, ECOG PS, LV score, and tumor burden score. Here also, there was a significant advantage of PFS, and the hazards ratio was 0.66. At 12 months, and also at 18 months, the curves were widely separated. There was also a trend towards improvement in the overall survival with the addition of Lenva, Pembro, and TACE. When we talk about the adjuvant setting, we have this trial Keynote 937. It actually it showed that there is no advantage of adding pembrolizumab in patients who have resected HCC. The eligibility criteria were basically confirmed HCC. Uh, Predominantly after surgical resection, they were randomized into pembrolizumab and placebo. So this trial showed no advantage of addition of immunotherapy. However, the OS also was uh, overlapping. However, when we talk about IM Brave 050 study, they have actually included the patient's post-resection high risk features. So, high risk features include tumors more than 5 centimeter, more than 3 centimeter tumors, macrovascular invasion, uh, you know, and minor macrovascular invasion, BP1, BP2, or grade 3-4 pathology. So, they were actually randomized into active surveillance versus atezolizumab for 1 year. In this, specifically in this study, it was a positive study, and there was a difference in the recurrence-free survival at 12 months and at 18 months. So maybe there is a predominant role of VEGF. We can see that previously also Renuka ma'am discussed that, when we talk about the predominant three trials, whether it's Durva-Tremi or Atezolizumab or the Pembrolizumab or Nivo AP, we have seen that the data of Atezolizumab, I mean, personally, I always use Atezolizumab in my as my first choice. Maybe there is you merit to addition of VEGF with the immunotherapy. So that is the mechanism why we can see the adjuvant IM Brave 050 was positive, but the adjuvant pembrolizumab was negative. So coming to the future trial opportunities, we can always have targeted therapies, AI-driven drug repurposing. There is no field where AI is not being used now, and definitely it is also coming big time in healthcare. So the strategic opportunities for Indian researchers, collaborative leadership, cost-effective designs, expeditive regulations, and global data integrations. So a roadmap is global partnership, national registry and awareness, leverage AI in the data, and capacity building. Barriers we have discussed predominantly. There are barriers in every country. However, we need to address them, and we need to find a way out to bring in the more and more people enrolling in the trial and bridging the gap. With this, I would like to thank you so much for your patience listening.
Thank you, Darshit. Um, Thank you for shedding some light on the Indian scenario. With this, we move over to the panel discussion, and I would also like to acknowledge some of the seniors that have logged in. I saw Dr. Talati logged in as well. That just speaks for good evening, sir. Priyanka's
Everybody,
thank you. Thank you for logging in. And that's a validation to this forum, truly, because, main thing that this forum is trying to do is bridge the gap and spread the knowledge. And truly welcome all of you for this next session that is coming in. Interesting discussions amongst the center leaders. We have Dr. Tushar Patil moderating. He's a consultant medical oncologist from MOC Pune. Dr. Mihir Vora, who is this is Assistant Director of the Outreach Center for Oncology at Sir H.N. Reliance Foundation Hospital. He is in the division of hepatology. Dr. Ravi Jaiswal, he is consultant medical oncologist from Care Hospital, Rajputana Care Hospital, Barmer, and Dr. Abhishek Kakru, who is from HDC Vedanta Hospital. He's a consultant medical oncologist, and Dr. Taha Sethjiwala, who's a consultant medical oncologist from CMC Cancer Care, Indore. So
MOC, ma'am, I think. Very wrong. MOC Indore, ma'am.
MOC Indore, sorry. And welcome all of you, and turning it over to Dr. Tushar Patil to take over the moderation. And also, thank you all panelists for joining in.
Good evening, everyone. Am I audible?
Yes, we can hear you, Tushar.
Good evening, everybody. Am I audible?
Yes, sir.
Okay. So we begin our panel discussion. Happy to have Dr. Mihir Vora, Dr. Ravi, Dr. Abhishek, and Taha for the panel discussion here about how do we choose our therapies for unresectable HCC and thereof immunotherapy. Would ask the organizers to advance the slides for me. So this will be Globocan data. I think liver cancer now contributes. It's the 11th most common cancer type as per the type, and 8th most common cancer as comes with for the cancer related deaths. It's being the second most common cancer death is men. Taha, the question is to you. Have you seen the paradigm change in the etiology based HCC diagnosis that you're coming across various patients?
Yes, sir, absolutely. There is a change. Seeing more of viral etiology earlier. Now it's more of these lifestyle oriented, sir. NASH and all those things. More of such
Absolutely.
etiology, yes, sir.
So as we can see, the incidence here in India, 2022 Globocan, 38,700, and amongst this, the alarmingly high, 36,000 being the deaths, and striking difference in males and females. The males, 26,000 as compared to 10,000 in females. So there is almost a 2.5 to 1, or maybe even higher ratio male to female. And yes, definitely the incidence is quite high uh, in males. Incidence of HCC in cirrhotics in India is 1.6 per year, percent per year. That's how it is. Next slide, can we have? So this is the thing which we are talking about, that there is a shift now from viral to non-viral etiologies, which includes commonest being the NFLD, non-alcoholic fatty liver disease. Abhishek, I would like to ask you a question. How many cases of HCC on an average do you see per month? Advanced HCCs?
Good evening, Tushar. So basically, first
Hi.
of all, you will see advanced HCCs only. We rarely see early stage disease in our clinical practice. That is a difference from what Dr. Renuka and Milind are practicing probably there. And you tend to see at least about 10 to 12 patients every month with an advanced HCC which is very difficult to compare to the data that was put up by Dr. Renuka in a clinical trial. So, uh, Tushar, just after answering your question, so your panel discussion does not match the excellent lecture that Dr. Renuka has already given. Maybe you can put up an interactive discussion because there are several questions in the chat board also, and I think Dr. Talati is there waiting to ask a few of them.
Yeah, so I think sir is welcome to ask
Because
the questions
whatever you
in
are
between
discussing
also.
has already been discussed already.
Yeah, sure, sure. Can we have the next slide? Yeah. Next, again, we've discussed it. So again, Abhishek, question for you only. Well, does this etiology influence your treatment choice at all? And how do you go about defining your treatment for advanced HCC, whether it's a viral marker positive or NFLD related disease?
So I think there was a lot of talk about viral being treated in a different way, and I think the previous lecture, Dr. Renuka clearly showed you that I think it's just a more of an etiology rather than a treatment. And I think what is more important is whether your patient is fit enough to be receiving an IO plus BEV, and is the right patient being treated for the right treatment. I think that is more important rather than etiology being chased.
Okay.
So I have
So
a,
Ravi,
sorry,
if you can
Tushar.
just elaborate on, yeah,
Tushar, I have a question here. I'm trying to find out, like, I think what I mentioned earlier is that the metabolic disease is rising here in Texas. Majority of our patients are that. Unfortunately, back home in India, I think diabetes is going to be the major health risk factor for people over the age of 40, which is
yes.
where the incident it's among the highest in the world. So, do you see that in terms of your uh, shift from viral etiology to metabolic disease? Do you see a difference in, have you changed your practice in any way for managing HCC, or do you see a different pattern? And I'm also going to open it to Renuka. Like, how, besides, of course, the antiviral treatment, are there any subtleties to managing these two different disease entities, HBV or in US HCV related HCC versus metabolic disease, which related HCC, which is a growing problem all over the world? So let me start
Dr.
with you,
Renuka?
Renuka.
Um, Great questions, Milind. I think that the three things that I've seen in my clinic relating to this etiology question, or sort of things that have come to my mind is when I see the patient, I want to know what the etiology is. And it's surprising how many patients come and they still don't know why they even have the HCC. They were diagnosed because they just ended up in the emergency room and somebody did a scan, and some of them still have active anti-H have hepatitis, chronic hepatitis C in our clinics here, and they need to be treated. And so I do make that referral to treat them, because even if their LFTs are so-called okay for IO therapy, we know that if their LFTs start to bump up, it's going to be hard to tell, is this from HCV flares, which we know don't happen often, or is it going to be as an IO toxicity? So I feel like that's one thing, in our clinics, just screening for it to first know what is the etiology is sort of like factor one. I do sometimes see patients who don't have NASH, or they might have been drinking. They have like three, four things going on. So it's a little hard to tease out like what exactly did cause this person's HCC. And so having those mixed etiology cases does make it tricky, because you don't know what the real cause is. And until we have some sort of immune biomarkers to tell us, what might be a way to detect who is the person who's going to get a response, until we analyze those 20% of people who are at the tail of the curve, who are getting that big response, it is not that easy to tell that this is a purely viral, purely alcohol, purely NASH person. By default, we call all of them NASH when we don't find virus. So that's just something also to sort of keep in mind. And then the third thing is that, in the absence, when you have low platelets in somebody, for example, some of these patients have hypersplenism, their platelets are 30, 40, they're sort of just hovering in that number. their INRs are a little high. That treatment with BEV does become a little tricky. And so even VEGF therapies, even orals, you worry about them, having a little, even just a slight drop. You don't see grade 3 and 4 thrombocytopenias with the TKIs, but the concern is that they're going to bleed, they're going to have epistaxis, they're going to have some issues. And so that immunotherapy option does become more attractive. And I feel like that drives the decision in the clinic much more than what really was the etiology.
Yeah, I just want to remind the younger people in the audience that the
Yes.
problem with MASH and MASLD is, you have exhausted T cells. So you have markers of T cell suppression. You have high Tregs, you have PDL1, TIM3, LAG3, etc. Uh, you can actually have high CD8 cells, but they're ineffective. And so these exhausted T cells can sometimes be influenced and be recovered by immune checkpoint inhibitors. So James Allison, who is one of our seniors at Anderson, got a Nobel Prize for this, first showed that the CTLA4 is a checkpoint can be inhibited in these exhausted T cells. So this is the underlying mechanism why we think immunotherapy works. But Tushar, I also want to learn from you, like access to these therapies is a big problem, right? In India?
Sir, access is not no big problem now. I think the availability is there across all cities. So Atizobev has been there since a long time. Durvatremi has come uh, at least 3 4 years now. Nivo EP is there. All these are established treatments and they are available. Of course, there are generics of these coming, and more usage would be there in the coming days now. So Nivo generic is already launched in India, and we'll be seeing more and more generics being used across various indications of immunotherapeutics. It will be there. As Dr. Renuka madam has already pointed out, yes, from my practice also, usually there's no difference in how I practice based on etiology, but uh, many times we come across a patient who needs a scopy to be done before atizobev, and the scopy shows that there is a varices which needs to be ligated or banding is done. So the first cycle usually I skip the bevacizumab in such cases. Usually, I just give the immunotherapeutic agent atizo, and maybe once I'm sure that the risk of bleeding has gone down significantly, then the bev is added.
Tushar, just to add to what you were saying to Dr. Milan's question, is that probably you can correct me if I'm wrong. I've seen two sets of patients. One is now you see affluent people developing, more than affluent, you see a middle class or a good person developing HCC, probably due to steatohepatitis or fatty liver or whatever. And in India, you still see a lot of patients who are from the lower strata and have the viral induced HCCs. And those are the difficult ones to manage because they always land up with advanced disease and very limited resources. We still are stuck up with those guys.
Absolutely, yes. What I'm saying is, I think the first question is that here the treatment would be based on evidence based rather than the cost based. Yes, for cost purpose to oral TKIs which are easily available and easily manageable in the long run for most of our patients. Can we have the next slide? We have had patients where, hello, am I audible? So this is the spectrum of the drugs that we made available. So Rafenib to the today present day era where we have all the immunotherapeutic drugs available to us. Next slide. Uh, Again, I think based on the staging and how do you, Dr. Ravi would like you to take up this question. The next slide, please.
Yes. Yes, Dr. Tushar.
Yeah, please. So, cost being no bar, the previous,
So, what is
I
my
think,
current choice of
discussion.
treatment for patients with? Yeah. So, Dr. Tushar, earlier I used to use a lot of atezo-bev in my practice, but honestly, my patients did not derive that much of benefit as the clinical trials have reflected. And of late, I have shifted my practice to atezo-bev, and I have four patients consequently on that, and three of them have shown excellent response. So I am more tempted to using Tremely and Durva in my practice, and I find that very easy for the patients to handle. And uh, even one of my patients on this regimen uh, is, in complete remission. So I think though the data is showing only 16 months there, but I think we need to look at the tail of that curve where 20% of the patients at I am more biased towards using Tremely and Durva in my practice. Thank you.
So, yeah, can you give us an exact indications of where you would be using atezo-bev as compared, where you would you prefer atezo-bev as compared to Durva trimming?
So if you want to ask that question, I think the advantage of Durva with Tremely is that you don't need a patient to undergo, even if they have varices. Even then, you can give this regimen. But then, if you want to compare based on etiology, let's say NFLD versus viral etiology, I think even for NFLD and non-viral, the stride regimen seems to doing well in my practice. So I'm not focusing on the ideology of HCC in deciding the management, and have shifted totally in followed by 4 weeks of Durva. So because I have not had a single patient out of eight where derived excellent response to Tizo Bev. So Bev, though look who have notorious to cause DVT, is notorious to cause bleeding, and somehow it did not work with my patients in my practice. Thank you.
Dr. Mihir sir, your thoughts on this? Uh,
Actually, I was just going to ask Renuka, but I'll just add quickly. I think they're both comparable. Atezo-bev has a longer track record, of course, and you find that I agree with what Ravi was saying, that we often have older patients or patients who have varices and risk of bleeding. For them, durvatremi is a good choice. I find the regimen actually quite easy to deliver. But for any time with, in my practice, when you have more than one choice, you generally develop your own comfort level for what you have and what the choices you have and which one you will choose. I think atezo-bev is still sort of, I think, the go-to regimen for most patients in the US, with durva-tremi as a close second. But if you feel in your practice is an easier regimen, easier to deliver with less issues like varices and thrombosis, etc., coming in the way, it's certainly a good way to go. Yeah, it's a good thing we have a choice other than
so any
sorafenib.
thoughts about, yes, sir. Any thoughts like in terms of the risks that there are, like invasion, macrovascular invasion, or water vein invasion, where any particular choice of drugs there, as per the trial data?
Yeah, and let me turn it over to Renuka. Yeah,
Yeah, no,
Renuka.
absolutely. And I can just pull that back up if, people wanted to just take a look. So in terms of the patients who let me just do a screen share. Mm, oh, are you able to see it or no? So basically, macrovascular invasion patients were present more in the IMBRAVE study. They were 40% compared to the Himalaya study, 25%. And extra hepatic disease, we had 60% in the IMBRAVE study compared to 50% in the Himalaya study. So if you were to sort of say like where do we have a little bit more data in terms of their response, how they're going to do, because when you think of macrovascular invasion, the question also becomes will they bleed? In theory, the concern is will they bleed? And that wasn't really the case. So I think that in terms of evidence of how many of these patients were included in the study, that we have safety data and response data, I think the atezo-bev might be slightly, at an edge. Of course, no, it's not good to do cross trial comparisons. And the same thing also for the VP4 patients, with the IMBRAVE study, overall response rates were 23% compared to sorafenib, where it was 13%. And these patients are just not going to do well overall. Their survival was 7.6 months versus 5.5 with the sorafenib. So keeping that in mind, that they're not going to do well no matter which option you choose. But if you had to pick, that might give us the best likelihood of a response. And outside the box in some of these patients, if only the thrombus is progressing or some of these nuances that we see, looking at some localized therapies, because I know one of the questions that has been asked also in the chat was, which may not be exactly this situation, but in general, the role of SBRT versus TACE was brought up. And those are the patients where, TACE really won't work. You can't access it. It's sort of like a little bit of a sanctuary tumor sitting over there. And SBRT could be an option for some of these patients, as well, because they do have superior local tumor control, 2 to 4 times higher. 90% of those areas that are treated with SBRT can actually shrink and get a little bit of a response. So some sort of outside the box thinking, if you don't get the desired response with the atezo-bev, could be something to consider.
So I want to make the point, Tushar, that I was taught by my seniors that always remember the treatment of HCC is multidisciplinary. So like Renuka said, include all of those therapies. I agree with you. I agree with that. Actually, durvalumab is pretty easy to deliver, but you do also have to think of multidisciplinary care in all of these settings. And one of the issues is liver disease. So, Mihir, I want to ask you, patients with HCC, a large number of them actually die of liver disease, right? Of liver failure. And how do you incorporate your practice in hepatology in management of HCC patients?
Thank you, sir, for the question. So, as you correctly asked, sir, for us, HCC is one of the complications of cirrhosis. This is going to be different from any other cancer which you see in any other part of the body. So, we have to take into account the MELD score, child score, decompensations, ALBI score before we decide any form of therapy for most of our patients. We'll be very lucky to get child A cirrhosis MELD of 6, not having any extravascular disease or even a portal vein invasion. And that's where, as you correctly put point, sir, from terms of MDT, we use BCLC, the extended BCLC, and the ASL, our Indian study, has done a very elaborate thing by splitting child B and child C into, when I say BCLC B and BCLC C, to B1, B2, B3, C1, C2, C3. So that has elaborated the armamentarium so extensively that we are able to choose loco-regional care along with their combined use of the TKIs plus immune checkpoint inhibitors and decide what is going to be the outcome. Also, sir, more important would be whether the patient is going to have a living donor ready, because what is the ultimate aim when you're treating HCCs? You don't want them to be in remission for HCC. The goal is to get the disease out, because that will give you the widest margin of resection. So if I have, as I heard few discussions from our respected panelists, to have remission for 1 year, 2 years is of no use. If I know my disease is under control and I have got a washout period of 3 months and a living donor is ready, that is the time I want to hit early and try to replace the liver, because that is going to give him the best possible survival chance. And that is where our whole MDT, with Shevanti ma'ams and team, our radiology team, our IR team, all of us get together every week to discuss every possible HCC to decide what is going to be the best outcome. It's not only about using immune checkpoint inhibitors, but a combination of all. So we use lot of albumin, we use lot of medical care to ensure that we keep the child status under control, so the therapies work longer and better. And that's where nutrition and everything will play a role. And to answer from etiology point of view, sir, still hepatitis B is very, very common in our practice. We are seeing a lot of NASH, no question about it. And that is where these two diseases get us a lot of multicentric HCCs. And that is why these therapies are going to play a very big role in trying to get our outcome.
Thank you, Mir. I mean, we have to remember India is like the world leader in generic medicines for hepatitis B. So we should be able to treat these patients with hepatitis B in an effective way. I think for time reasons, we have less than 15 minutes left. We can move to the Q&A session. So thank you very much, Tushar. And we'll just address some of the questions. What I'll do is, Renuka and the group, I'm going to read out some of the questions, and perhaps you can give us your advice. One of the questions is that, like child Pew versus Albi, what do you feel like in your practice might be the best way to go?
Yeah, I know, Tushar, you had prepared some of these slides as well. I would love to hear your thoughts as well. So, historically, the sort of history helps us to know how these studies came to be. And with the SHARP study, for the very first time, we learned that by using Child-Pugh, that was the best thing we had at the time, that you are able to filter out some of these patients whose livers are not, are really going to tolerate any of these agents, which are all liver metabolized, and also their liver function, especially for our populations that are very advanced, both in terms of the burden of disease and in terms of cirrhosis, that the magnitude of benefit is going to be so small that the intra-population variability is going to be bigger than the effect size. You got to take them out, and that's the only way. And that's why they even did the Asia-Pacific study separately, and that ended up being the case. There were some differences in the placebo arms as well. So right now, in terms of the guidelines, if we were to be purely evidence-based, and as my program director, Dr. Levine, who's very, sort of a purist, would say, the Child-Pugh is still the eligibility criteria for the selection to enroll the patient or to start the treatment of the patient. But as you know, all these patients don't fare the same. Some of their livers sort of go downhill and they sort of progress. And that's where the ALBI really helps. And that's where you can sort of distinguish and create like these little subsets, because as one of the speakers earlier said, we all want these perfect Child-Pugh class A people. But within that Child-Pugh, there are so many things that can make their Child-Pugh score bad. If it's something that's manageable, like ascites with good diuretics, that's different than a bad bili. That's a whole different sort of picture. And so with ALBI, you're picking the two that are a little bit more not susceptible to those kinds of variations, and are truly measuring the liver function. And so the delta ALBI, I find to be a little bit more useful in predicting how this person is going, and that can actually help guide you in terms of the aggressiveness of the second line therapy. For example, I don't use it to change the existing therapy because I still use my RECIST, my clinical progression, and so on. But those deltas are helpful in knowing this one's not going to be good. I need to start looking at a trial for this person. And those changes allow me to select that second line therapy and decide how aggressive I'm going to be. I hope that answers your question. And I'd love to hear from others. I know, Tushar, you also had some thoughts on this.
I think I perfectly agree with you Gautam, that to go is child book that we are using most commonly and most frequently to prognosticate this patient also in terms of how bad the liver is, because he's fighting two diseases, liver cirrhosis and the HCC both. So usually we go by that.
So one of the questions, Semanti is really like the leader in precision oncology in the country. Like, NGS is like commonly used for everything. Do you do it for your HCC patients, and do you see any value in it?
So I actually end up doing it for patients who have tissue, and occasionally I have gotten lucky in a pathway or two, but largely the difference in practice between how we manage HCC and other liver-related malignancies like cholangiocarcinoma or gallbladder cancer is that those are target-rich diseases, and HCC is not as much. Plus, the frontline therapies are all they are general. They are not pathway specific. So broadly, they are still targeting, but they are not that pathway specific. So for HCCs, I have not had that much benefit in finding targets. Even when I have looked, it's mostly FGFR expressions and not essentially
Right.
fusions or mutations that I could target. And so those are the challenges. I do want to present a quick question. I know it's not written in the chat box, but I'll take the liberty. So I'm supposed to speak on a big hepatology meeting that Mihir Vora and seniors are organizing, Dr. Akash Shukla. And I just want to second what Mihir just said. We are proud to call ourselves a Center for Excellence in Hepatology. The hepatology division is led by Dr. Akash Shukla. Mihir is a part of his team. And Akash is very, very diligent in how we conduct HCC decisions. And it is a multidisciplinary team. We are very particular about that. And diligently, they run this service week after week. So we get the opportunity to get together and present. And I think that's where I'm coming to with my question. So I'm doing a debate on who anchors the therapy. And of course, I'm the medical oncologist and I'm pitched against a hepatologist. So I wanted to ask this question to Renuka. What do you think? What happens at your center?
I think it's the person who is the most vocal or the biggest advocate, for the patients. But sometimes it's the most senior. But I think in reality, it's the person who has that sort of networking ability to pull all the parties together and get the right person in the right room at the right time without any delays. And I think that just sort of underscores the importance of what the Jarurat Care Foundation and a lot of the network navigators and nurses and other care coordinators, social workers, or whoever else runs your clinic, clinic managers, is important. Because after these multidisciplinary discussions, once we know what the patient needs, communicating that to the patient and getting the patient into that right spot is always still left up to the provider, and that is a little hard to do for you, busy doctor running practices, running programs, teaching, and so on and so forth. So whoever can sort of put those processes and systems in place and create those sort of SOPs and things is the one who should run it. And it's not that the hepatologist can't do it, they most certainly can. But these subtleties now, in the beginning, they were all giving sorafenib, a long time ago when that was the only thing available. They said, we can do this, no problem. But as things have become more nuanced and more complicated, I think we've sort of shied away from getting into the anti-HCV drugs and said, hey, you guys do it. And the same thing you've also been, at least the hepatologists have been saying, like, we'll manage the ascites, you take care of the rest.
I think you've said it very well. I think the underlying message is get the patient to the multidisciplinary team, which includes the medical oncology team. Our roles used to come in much later, but I think the earlier, the better, the sooner, the better now, because of all the different options we have. And picking up a case, understanding how to come in from a medical oncology perspective earliest possible remains the writing on the wall. And the cases may be anchored on from any side. From in at our center, definitely Dr. Akash Shukla, because he's the rainmaker.
Yeah, but Sevanti, it's like, like Renuka showed the Emerald studies and everything,
Yeah.
where these systemic therapies are being moved earlier in that.
Yes.
So
Very.
we have few minutes, so I want to also not forget the questions regarding regarding liver-directed therapy. So you have TACE, you have Y90, you have radiation therapy, you have now histotripsy. Let's not forget liver transplantation. So let's leave the liver transplantation out because certainly people who get that should go there. But there are many of these options available, and choosing those and the nuances is tricky. So, does Renuka, you want to comment? I mean, there were some questions on how do you choose now? Like, why not? I imagine taste is more popular in most part of Asia. In US, we have really transitioned to Y90 for the most part. But any thoughts about how do you do this?
Yeah, I think exactly like you said, Milan, there was a time when the patients were getting taste. And then by the time they came to us, their liver was, not really healthy enough to get anything. And as we're getting these bigger responses and we're going to tumor boards and we're showing our radiology colleagues like, hey, these tumors can actually shrink now. They are also saying like, can you add this adjuvantly and make sure that we don't have to go and taste them twice a year? We'd rather go in there once every 2 years if we can. And I think that's better for the patient. And they are now sort of engaging us and saying like, come, like add these things to what we're doing. And that's what Emerald study gave us, 15 months versus 8 or 9. And I think that once you start to see that big of a difference in terms of a liver intervention, when the therapies don't have that much of a toxicity or whatever toxicities they have are manageable. And I just wanted to make one more point, because the question of atezo-bev versus durva-tremi in terms of combinations, yes, the bev has that anti-angiogenic, reducing the tumor permeability. So in these settings, that atezo-bev might, or bev in general, kind of in the combination might win out a little bit more in that setting, because the thinking is this is an earlier stage, and at this point, it's the anti-vascular revascularization that you're trying to go at a little bit. And in terms of toxicities, the fear is, hey, listen, you could get the same benefit from the liver-directed therapy. Do we really want to add the immune toxicities? Because those are the ones we're most scared about. And one thing to remember is that with atezo-bev, the immune AEs requiring steroids were 12% versus with durva-tremi, it was 20%. So even though numerically the total number of grade 3, 4 toxicities were a little higher numerically with atezo-bev, in terms of the scary immune toxicities, the percentages were lower. And it does add, the immune toxicities do go up more once you add the durva to it. Not always fatal, still manageable, but just some things to keep in mind. And the other question that also comes up is, will surgery come back into the table, come back into the option, like is kind of like a neoadjuvant? Like, would that be an option with all of these different things that we're doing? In theory, yes, if that is an option, we should revisit it. That tumor board, like, Dr. Limay said, like, keep discussing, see the response, don't go there to brag about the response, but just go there to ask, can we get rid of this? What else do we have? But a lot of the data we have right now is really only adjuvant in the HCC space. We don't have a lot in the neoadjuvant space, unfortunately. And I think some lessons to be learned from kidney cancer, because a lot of the neoadjuvant checkpoint inhibitor usage, mostly with TKIs, because there's more safety data that you can give the TKI up until the day of the surgery, because there's a lot of fear that giving bevacizumab will cause, wound dehiscence, delayed wound healing. So if you're going to do atezo-bev, someone had asked that question neoadjuvantly. I'm not aware of any data to that effect. The question is, when are you going to stop the bev? And that sort of is an issue that we have. And in terms of the time before you give the therapy to when the response is going to occur, with durva-tremi, 39% of patients had progression as their best response. And that happened very early, like it was their very first scan. If they're not going to respond, you'll know it pretty soon. And with atezo-bev, it was 19 to 20%. So yes, the percentage responses, for example, with ipi-nivo are higher, but if it's also not going to work, you're going to know pretty soon. So those are, some of those options that we can sort of test early. And with the very first scan, you're going to know, is this someone that's headed in that direction or not?
Yeah, I think we have just a few minutes left, and I just want to also remind the audience that very interesting studies, like Renuka mentioned, from recently from China and in Lancet with neoadjuvant. So maybe that's phase 3. So maybe that's the direction. Before I close, I want to ask Dr. Talati, who I'm sorry to call you senior Dr. Talati, but certainly an experienced oncologist in the community for a long time. Do you have any other final thoughts before we close?
No, no, just wanted to know from expert, Milind. But anyway, hi to you and hi to Renuka. It was great hearing her talk. I attended one of your programs at Tata Memorial on, I
Yes.
think, cholangiocarcinomas. Yeah. So
Yes.
my question to expert was, when do you prefer Y90 as a major portion or part of your management planning? Do you think
So
we
I'll
should be
quickly,
using it more often?
yeah, I'll quickly answer that, Dr. Talati. I
Hmm.
think it's a wonderful therapy, but I also want to caution people because it has to, like radiation therapy in SBRT is done in a careful way with dosimetry calculation. Surgery is done in a careful way to calculate liver volume. Y90 is extremely effective. We have largely replaced TACE with Y90. But we have also realized with time in America that if you don't give it in a judicious way, you get a good response, and within 4 or 5 months, patient has developed ascites, liver problems, and liver failure. So I think it's an excellent replacement for TACE because it's very directed, very specific, but it has to be done in a very careful, calibrated way by somebody who's experienced. And we went through that transition ourselves at MD Anderson, where 10 years ago I was worried that you get a good response and then a few months later the liver has failed. That has completely changed now. I think, Renuka, you'll agree, where you can give it safely, you can preserve liver volumes. And I think you will go through that yourself in your practice, Dr. Talati. I think it's preferable to TACE in most instances because you can treat multifocal disease, you can
Correct.
treat, the underlying liver, you can spare normal liver parenchyma if it's done in a careful and calibrated way. So I think you'll develop your own expertise and you'll develop your own liaisons with your radoncs, but do keep in mind that in the initial phase, you will see some downhill, people going, being troubled by liver failure.
But
Yeah.
how are the responses in general and the duration of responses with?
It's excellent. Yeah. Renuka, do you have any thoughts? Yeah.
Yeah, book answer somewhere between 25 and 50%. Also, definition of response, modified RECIST. But by modified RECIST, there are many complete responses and excellent durable responses, even with partial responses. And the median duration is somewhere between 9 and 14 months, sort of average in terms of disease control. But now we'll wait for the readout on Emerald Y90, and we'll be able to sort of share with you if that was, really extended. And we are going to compare it to patients. We have some intrinsic control data with some Y90 alone so that we can tell you relatively what that looked like. So more to come. In another year, we should have that data matured. We just
Great.
finished enrollment in November.
So so I want to thank everyone. We have come to really extend it a little bit beyond our time. So Sevanti and I really are very grateful to you, Renuka. First of all, I'm very proud that you're from Mumbai, really from Grand Medical College, my own college, and then she's gone to Cornell and then the residency in Roswell Park, and now joining NCCN. Of course, my underlying agenda is that I'm tired of seeing ESMO guidelines in India. I want Indians to develop their own guidelines. This is an ideal disease. Renuka has a pathway forward, and I can't speak for her, but I know she will do everything possible to assist in that venture. And of course, I want to thank Priyanka. Priyanka, thank you for getting us all together and to learn about this difficult disease that we hope to conquer within our lifetime. Thank you again, and we look forward to the next meeting.
Thank you so much. And we will be sharing the recorded session and meeting summary soon with everyone. Thank you, everyone. Yeah, have a good day. Have a good night. Thank you. Bye bye.